My name is Thomas Goetz, and I have a fellowship in trauma and then a second fellowship in upper extremity microsurgery. So when you're asking why do I do orthopedic surgery and what's my philosophy of my job, or what draws me to it, well, I was formerly an engineer, and so I'm entirely mechanically oriented and a fix-it kind of personality. And the advantage of orthopedics is they're usually short problems. You have to diagnose a problem, you have to work through a solution, and then get it done. And once it's done, it's finished, which is what attracts me, is aliquots of problem, fix it, move on, do the next one. So a typical elbow injury either comes through the emergency department at my hospital or is referred directly to me from another hospital because I'm an elbow subspecialist. If the fracture is a very severe one or associated with other injuries or impending soft tissue compromise or an open wound, that would be directly admitted and we'd see it on the floor and deal with it directly on the trauma room. But when they come to the clinic, they're assessed, may or may not order further imaging and decide upon a plan of surgical treatment, which is then done generally on what we call a trauma day, and then the patient will follow up. For elbow injuries and trauma, we actually have a database, so we keep track of them, particularly the various posterior medial rotator instability. So hopefully we can see them many years down the road to be able to monitor whether or not they're developing long-term consequences as a result of their injury or treatment of it. Essentially, the numbers and the data for rare injuries in the elbow are very low, and so all of the literature is essentially level 4. People have looked at, we did this number, and this is what we saw, or you pool it from various centers and different surgeons and different techniques trying to improve the number of patients that you have and therefore the accuracy of your estimates of outcomes. But ultimately, you'd like to have longitudinal data that will tell you long-term. And so what that requires is registering the patients at the start, registering what their injury is, who they are, and keeping track of them. I see a traumatic elbow, either acute or subacute or for revision. And I see cold elbow orthopedics, so elbow arthritis of the various types and elbow instability problems. And they constitute between 30 and 40% of my practice. The rest is wrist, hand, and microsurgery. So that's a very broad question, but your question is sort of what are my indications for surgery for elbow conditions? For trauma, it depends on what that trauma is. It's the terrible triad, and the indications of surgery are fairly clear. If non-operative treatment is going to fail, then you go for surgery, and it's easier to convince a patient in that case. For cold orthopedics such as elbow arthritis, you really have to look at the type of arthritis. Is this an arthritis where the entire joint is damaged like rheumatoid arthritis, or is this an arthritis where the pain is only at the end of range of motion, which is more osteoarthritis, and what kind of operation are you going to offer them? You have to look at the patient. If it's a baseball pitcher who has a medial collateral ligament injury and has pain when they pitch, but they only pitch in the weekend league, you can tell them, if you don't pitch, you don't have pain, and sometimes that's all they need to hear. What are the most important aspects for function and stability in reconstructing elbows? Essentially, what you need to do is pare down the critical components of an elbow, and the critical components of the elbow are the anterior half of the trochlea, the capitellum, and when you look at that anterior half, the critical component is a combination of the medial ulnar trochlear joint and the radiocapitellar joint. So what that says is bony anatomy is key. So even if it means getting a stiff elbow, you have to restore bony anatomy that makes an elbow. Otherwise, you don't have an elbow. You've got something else. So you restore bony anatomy, and then you worry about motion, and then you worry about stability. In terms of a terrible triad, what's most difficult to treat and what's most important to do well, the most difficult to treat is a coronoid fracture because they can be difficult to access without significant dissection, and they can be difficult to fix securely. However, it is becoming increasingly evident that essentially for most coronoid fractures that are associated with the terrible triad injury, you don't need to replace them so long as you've restored the lateral column, which is a radiocapitellar joint, either through fixing the radial head or replacing it. And the most technically difficult part of that is certainly fixing a fractured radial head in a young patient that you'd like to avoid arthroplasty. And the most important component ultimately is to restore the anterior bony anatomy such that with appropriate ligament repair or immobilization and future release, you maintain the critical bony elements of an elbow. And coronoid injuries are divided into tip fractures, anterior medial fractures, and basal fractures. And it is well known that a significantly displaced basal fracture no longer longer qualifies as an elbow until you reduce and fix it, and that's a good way of thinking of it. A tip fracture often is well tolerated and doesn't need to be treated. In fact, some evidence suggests that if you over-treat them, you have increased risk of stiffness and heterotopic bone postoperatively. And the anterior medial one is a relatively recent one that people are still investigating. We're not sure which ones can be treated non-operatively, even in the undisplaced group. And everyone's fear of the anterior medial coronoid fracture is how do you fix it and how do you access it? And I think that is one of the things that has deterred people from treating them aggressively and appropriately. The work we did today in the lab is trying to demonstrate that actually accessing those fractures is not as difficult as people think and can be done safely without a threat to the structures on that side, particularly the ulnar nerve. So post-surgical instructions for coronoid fractures depend on what type of coronoid. So if you're talking about anterior medial coronoid fracture and the varus posterior medial rotary instability pattern where you have a lateral collateral ligament subsurface tear, it's actually often, we've been shown it's actually often more than a subsurface tear. You have to protect the collateral ligament repair and you have to protect your anterior medial coronoid. Now, phylogenetically speaking, the anterior medial facet of the coronoid is very thin. We come from monkeys who are hanging from trees with traction, but we spend our lives working like scarecrows. Essentially, we have our shoulders abducted and our arms out. We're typing, we're lifting, we're doing things with our arm. And what that does is it puts a moment arm on the medial side of the elbow and a varus force, which will stretch the lateral collateral ligament and put pressure on that very thin antemedial facet fragment. And so you will stress that fragment and you'll stress the fixation holding that fragment. So the key to the post-op protocol is to avoid varus stress during the rehabilitation period. And previously there was a lot of motion, a lot of effort to trying to make braces with an axis that allowed motion with the brace on, but the problem is they don't stay in one position, and so you can actually be stressing your repair. So my protocol is to immobilize in a back slab splint, and then when they come out to do exercise, I tell them that they have to have a vertical humerus with no shoulder abduction. They can have shoulder forward flexion, but no abduction, and do exercises in flexion and extension. In terms of whether to be in pronation, supination, for that particular injury, it hasn't been shown yet, but I suspect strongly that actually pronation is a position of safety. Before deciding on an implant, you have to try it and trial it. You'd have to know that the company has done their work in terms of producing plates that are strong and that allow periarticular fit, that they're reliable and dependable in terms of their organization and presentation of the product to your hospital and training. In terms of coronoid fixation, I think a key element that is available that Acumed provides is the titanium threaded 6.2K wire. You can expose the fracture, and you can often find that the fracture fragments are very small and very difficult. You wouldn't be able to hold them with an interfragmentary screw, even a very small one, and you wouldn't effectively be able to hold them with a plate alone. So the threaded K-wires can hold the fracture from multiple directions and as a raft just below the subchondral surface. And then you can place a plate on top of it to neutralize it. I think companies do an excellent job. I think that's born out of competition in the United States, that they have tailored their services to specific injury patterns, and they're listening to the surgeon, and that really has been the key in development of a lot of excellent products in the last 20 years. Acumed, I think, has been particularly good at that in the upper limb, which is an area that is my subspecialty, particularly about the elbow, and I think that their advances in the elbow essentially have revolutionized the fixation of these fractures. And the improvements in fixation techniques, in plate design, and screw design, and the very plate placement technique has allowed a revolution in the ability to fix these complex fractures, and to the point where I rarely will do a total elbow for trauma, even in an elderly person with very poor quality bone.